Good morning. Today we'll have a case discussion on Cleft, Palate and Palate. The case will be presented by Dr. Shreya Shaha, who is a third-year junior resident at IPGMR SSKM Hospital. And today with us will be Dr. Kollan Das, who is Associate Professor of Plastic Surgery at IPGMR SSKM Hospital, Kolkata. So Dr. Kollan Das will take the scenario as it goes in exam. So Shreya, you can start sharing your screen and present the case.
Sir, am I audible?
Yes, you are.
And is my screen visible, sir?
Yes, it's visible.
Yes. Please start.
Okay, sir. Good morning, respected teachers. And today I am presenting a case of cleft lip and palate. My patient is baby Titli Gupto and the informant is Mrs. Shopna Gupto, her mother. She is a 15-month-old baby, female gender, resident of Tollygunge, and was admitted on 3rd February 2022, and the date of examination was 4th February 2022. Her chief complaint was a gap in the roof of the oral cavity on the left side since birth, and she also complained of nasal regurgitation of milk during feeding since birth. History of present illness. This child is a firstborn child of parents aged 23 years, mother, and 37 years, father, from a non-consanguineous marriage, presented with history of split in the roof of the oral cavity on the left side since birth. There is history of difficulty in feeding as well as that of nasal regurgitation during feeding since birth. There is no difficulty in speech till now. She can only say ma and baba. No nasal intonation noted in her speech till now. She also had a defect in the upper lip on the left side since birth, which extended inside the left hollow of the nose, which has already been repaired by a previous surgery, and the details of which have been mentioned later. There is no defect in dentition, and there is no history of any respiratory complaints or spells of bluish discoloration after birth. Past history. She had a history of defect in the upper lip on the left side since birth, which extended inside the left hollow of the nose, which has been repaired by a previous surgery done at our institution when she was 4 months old. Birth history. Antenatal history. The age of her mother during pregnancy was 22 years. There is no history of any infection during pregnancy or any gestational diabetes mellitus. History of intake of anti-epileptics is present since last 10 years. And also she took the medicines throughout her pregnancy. There is no history of threatened abortion or radiation exposure. There is no history of consanguineous marriage, no history of alcohol intake or smoking. Natal history. The child was born at term by normal vaginal delivery at a hospital, and she cried at birth. Her birth weight was 3 kgs, and there is no history of any spells of respiratory distress after birth or need for prone position. Postnatal history. There is no history of recurrent ear infections or ear discharge. There is no history of upper respiratory tract infections. Immunization status. She received BCG, OPV0, and hepatitis B at birth. And after that, she has received all the vaccinations and she's up to date for age. Family history. There is no history of similar or any other congenital anomalies in the family members. Moving on to examination. General examination. The baby is active, alert, and playful. There is no cyanosis. The vital parameters are also within normal limit, pulse rate being 96 beats per minute, blood pressure is 90 by 60 millimeters of mercury, saturation is 99% in room air, and she is afebrile. The anthropometric measurements are adequate for age, height being 52 centimeters, weight 10.4 kg, head circumference 45 centimeters, and mid-upper arm circumference 12.5 centimeters. The systemic examination was also within normal limits, and no other congenital anomalies were noted during examination. Local examination of the lip revealed a visible scar marked in this picture by an arrow on the left side of the upper lip at the site of corrective surgery for cleft lip. The examination of the nose was also within normal limits. Alveolus, there is no discontinuity of the upper alveolus. There is mild protrusion of the upper alveolus as compared to the lower alveolus. The child has 5 teeth in total, 2 upper central incisors, 2 lower central incisors, and 1 upper lateral incisor on the left side. The palate on examination revealed a cleft which was complete, involving both hard and soft palate on the left side. The gap was approximately 1.2 centimeters, and the edge of the vomer was visible in the midline. The soft palate was visible when the baby cried. There was no retrognathia, and tongue was also not protruded. Summary. Firstborn female child of parents aged 23 years and 37 years from a non-consanguineous marriage presented with history of split in the roof of the oral cavity on the left side since birth. She also complained of nasal regurgitation of milk during feeding since birth. She also had a defect in the upper lip on the left side since birth, which extended inside the left nostril, which has been repaired by a previous surgery when she was 4 months old. She has no difficulty in speech, or any history of nasal intonation is also absent. There is no defect in dentition. Her mother has history of intake of anti-epileptic medication before and during the antenatal period. Otherwise, the antenatal and natal period were unremarkable. After birth, she was detected with the above mentioned defects. Apart from these, no other congenital anomalies were noted. On general examination, the child is active, alert, and playful with normal vital parameters and anthropometric measurements. Systemic examinations were also within normal limits. On local examination, the scar mark of the previous surgery was found on the left upper lip. The upper alveolus was slightly protruding as compared to the lower one, with 5 teeth in total. On examination of the palate, a defect approximately 1.2 centimeters wide was found on the left side, involving both the hard and the soft palate. So my provisional diagnosis is that this is a case of a residual complete cleft palate on the left side in a child aged 15 months who has already undergone repair of complete cleft lip and associated nasal deformity on the same side at the age of 4 months.
Yeah, thank you, Dr. Shreya.
Thank you, sir.
It was a comprehensive presentation. Professor Shaha will be commenting
Very
better
good
on that.
This is what ideally one should present in examination. The presentation included the history of the lip, history of palate, and all the components of history and examination. But one thing I was trying to understand, this patient has got a complete cleft of the palate. So,
Yes,
patient who has got a complete cleft of the palate, there is some difficulty in pronouncing some consonants. Like you said, she can clearly say ma and baba. So they are the patient who likely to have nasal intonation. Dr. Das, what do you feel?
Yes,
With the
sir.
complete.
Absolutely.
So I
Absolutely,
was
sir.
wondering, if you are saying complete cleft of the palate, this patient may not have a normal speech development. There is some difficulty in speech also.
Yes,
yes, sir.
just off the record, Dr. Shreya, I wanted to ask that whether this patient was really like this, or you have thought that it should be like this. Can you tell me that whether, because you told that the cleft lip on the left side was complete because it extended to the nostril. That was your
Yes, sir.
description.
Yes,
So what I feel is that if it is complete cleft lip, which was repaired at 4 months age, there should be some, number one, there should be some nasal deformities associated. It may be mild, but it should be
Yeah,
there.
it is there. Mild deformity is still there.
Number two is that you have described the dentition as near normal. But in cases of the, as you know, that in cases of complete cleft lip, there will be at least notching of the alveolus and frequent missing of the upper lateral incisors. So your dentition should corroborate with your clinical findings. And also
Sir.
regarding the cleft palate part, you told that you have seen in your examination that the vomer is in midline, isn't it?
Yes, sir.
But you have described finally in the diagnosis as left-sided complete cleft of the palate. So if the
Yes,
vomer
sir.
is in midline, it is a bilateral cleft palate. In cases of a left-sided cleft palate, your vomer will be attached, one edge of the vomer will be attached to the right half of the palate, thereby giving a left-sided complete cleft palate. So these are the points which I wanted to mention in your presentation. And so coming to the questions, I think the most common way how a cleft palate and lip examination start is by the diagnosis. So it is a 15 months old female girl, female child with a left-sided, for discussion, a left-sided complete cleft palate.
Yes,
So
sir.
what are the problems of a child in a cleft palate? What are the problems?
Sir, yes, sir, the child has problems in feeding. There is nasal regurgitation during feeding, and also subsequently, there is, when the child starts talking, there is a defect in the speech. There is a nasal intonation in the speech, and there is also a possibility of recurrent ear infections, and there is a defect in the maxillofacial development, facial development ultimately.
Very good. So number one is feeding problems. So feeding problems occur because the child cannot completely close the oral cavity and thereby generate negative pressure for suction like breastfeeding, or there is nasal regurgitation of food materials into the nose. That is number one, and that may indirectly affect the growth of the child, the gross motor development of the child. Number two, you told that there is problems with speech.
Yes.
So what is the problem with the speech? Why the speech is affected in cleft palate?
Sir, there are certain consonants which require the touching of the tongue with the palate, and hence the sounds are produced. So those consonants won't be pronounced properly in these children. Plus, the nasal cavity and oral cavity are communicating, and hence there will be escape of air from the mouth through the nose. That will
The
also
nose.
lead to a problem.
To the hypernasality of the voice or the nasal intonation. So
Yes, sir.
yes, so at what age can you comprehend these speech problems in a child? At what age?
Sir,
At what age you can
around
understand?
sir, 18 months, around 18 months, when the child starts speaking in sentence, a few words actually, at
So in
around
the
18
language
months.
development of a normal child, the first thing what a child does is turns head to the sound. That occurs quite early. That is one part of the language development. And what we should know is that he starts monosyllables. He or she starts to speak monosyllable at 6 months, and bisyllable at about nine months to 12 months. So ideally, the speech assessment can be started from 9 months to 12 months onward, and it is a continuous process. In your case, since it is a 15-month-old child, I think you should mention that there is hypernasality of speech as well as nasal intonation when she is trying to speak certain words or certain syllables. The what you have mentioned, the palatal consonants. And the palatal consonant, can you give us an example of a palatal consonant? So
Yes, sir.
what word can the child tell so that the parents understand that there is some problem with the speech?
Sir, I can tell you the consonants K, then J, then these V. These are the consonants that require touching the palate. So words starting with these can indicate.
Yeah, so there are certain labial consonants like B and P, and there are certain palatal consonants like T. So if you ask the mother or the father, whoever is the caregiver, to specifically tell this. The third problem is the which may occur is the ear problems. So why does the ear problems occur?
So there are two reasons. Number one being that the milk that is milk or whatever liquid food the baby is taking, that is regurgitating from the nose and through the eustachian tube that is connecting the nose, ear and the nasopharynx. The infections can spread. And number two is that since the palatal muscles are not well developed, the the levator veli palatini that surrounds the eustachian tube and and is responsible for opening of the tube and maintaining the pressure on either side of the nasopharynx and the middle ear, that also is not working properly, and hence these problems of recurrent ear infections occur.
So what is the usual result of eustachian tube dysfunction? What is the manifestation? So
So
it is what type of it is a middle ear infection, inner ear infection, or an or external ear infection? What type of infection does it, or what type of inflammation does it cause?
Sir, it usually causes middle ear infections. The child presents with serous otitis media
Right.
or purulent otitis media.
Yes, right. So it is serous otitis media, and in some of the centers, the high volume centers, it is practiced to insert grommets while they repair the palate. So the fourth problem is the growth problem. What you have indicated, the what is the specific growth problem in the face?
Sir, maxillofacial
Yes, retrusion.
defects are there.
Yes, right. So there is less development of the middle portion of the face, the mid portion of the face, which is constituted by the maxilla and the zygoma. So this is uniform in cases of cleft palate, as well as in patients who are being repaired or who undergo cleft palate surgery also. So there is always this mid facial growth problems in these patients with cleft palate. There are certain other minor problems also in patients with cleft palate. And the list is quite long, but to know a few, you should mention the alveolar, that is the dentition problems. There is missing and malalignment of the upper incisors as well as the canine. So there may be adventitious tooth also, adventitious tooth that is a misplaced tooth. It can arise from the cleft margin. It may require extraction because it hinders the palatal surgery. If sir wants to ask something after this, I think.
Yeah, you said to go back to the clinical part, you said you have searched for other congenital anomalies. What other
Yes.
usual congenital anomalies are there with associated cleft lip? What you have looked for in this child? What are the
Sir,
other anomalies?
usually there are,
Yes.
yes, sir. Sir, there are vertebral anomalies, cardiac anomalies, anorectal anomalies. Then there are tracheoesophageal fistulas, and also there may be syndactyly, limb anomalies may be there.
Yeah. So you explain for those. So Dr. Das, we can discuss a little about the genesis of these defects.
Yes.
How does this defect develops?
Yes, Dr. Shreya, can you describe that how palate development occurs in few sentences?
So palate, your voice just broke, sir. Can you
Yes,
please
palate.
repeat?
Okay.
How does the palate develops? There are two components of palate,
Yes,
short and the
yes, sir.
short palate. How does the palate develops?
Yes. Sir, the development of the palate starts around 4 to 8 weeks of gestation, and it starts by the stomodium, the primitive stomodium, that is usually bounded cranially by the frontonasal process and superiorly and inferiorly on either sides by the maxillary and the mandibular prominences. From the maxillary process, the lateral palatine processes develop, and the median palatine process that develops from the frontonasal process. These combine, the fusion usually starts from the midline, and the anterior, it proceeds both towards the alveolus as well as towards the uvula. The point where this fusion occurs is known as the incisive foramen. The part anterior to it is known as the primary palate, and the part posterior to it is known as the secondary palate. The secondary palate consists of anterior two-third, which is the hard palate, which consists of the palatine process of the maxilla and the transverse process of the palatine bone. And the posterior part, posterior one-third of the secondary palate, consists of the soft palate, which contains muscular structures, and at the end there is the uvula.
So can you specify a little bit about the sequence of the development? Like initially, as you told, that the frontonasal process gives rise to the primary palate. The central four incisors up till the incisive foramen dorsally. Ventrally the incisors and dorsally the incisive foramen. So these develop from the frontonasal process, the extension. So the lateral palatal shelves initially, how are they oriented? Are they vertical or are they horizontal? So the lateral palatal shelves are vertical in the beginning, and the tongue occupies the gap in between the palatal shelves, the tongue. So once the maxilla and the frontonasal process, they are ahead in development, and the mandibular process develops later. So when the mandibular process develops later, the tongue drops down and the lateral palatal shelves from a vertical orientation, they come to a horizontal orientation. If there is disruption of this process, this gives rise to the varying amounts or varying severity of the cleft palate. Like you have mentioned in your history that there is no history of any respiratory distress after birth. What specific condition you wanted to mention through this?
Sir, in cases of
yeah, carry on.
Sir, in cases of Peary-Robin sequence, the
Yes,
patients have glossoptosis, retrognathia, and cleft palate. In those patients, usually respiratory distress is common after birth.
exactly. So what I was telling, that in case of this is a classic example, that this is the way how a palate develops, because in Peary-Robin, because the mandible is small and it doesn't develop and it doesn't drop down, the tongue remains in that position and doesn't let the palatal shelves to come from a vertical to a horizontal direction. So what specific type of cleft palate or what peculiar cleft palate shape of cleft palate can you mention in Peary-Robin sequence? Do you know how the cleft palate looks? It is horseshoe shaped. It is horseshoe, a U-shaped cleft palate. The defect is much wider because of this.
Okay, sir.
So what is your, how do you intend to investigate it in this case? How do you, what is your, are you planning something in this patient?
Yes, sir. I am planning a closure of the cleft palate in this patient, since the lip and nasal part has already been taken care of. So prior to that surgery, there are a few steps, a few investigations that I would like to perform. Now, routine investigations like baseline hemogram, complete hemogram with blood count, then a throat swab of the patient to be sent to look for beta hemolytic streptococcal infection. A thorough ENT checkup needs to be done. Then, sir, the weight of the baby needs to be the current body weight of the baby needs to be seen. The nutritional status needs to be seen.
Is chest X-ray important?
Yes, sir. A chest X-ray and 2D echocardiogram. Both these are to be done.
We do not do 2D echo in all cases of cleft of lip or palate. Specifically, if there is a history of growth problems, if there is a history of recurrent chest infections, only in those cases we go for screening echocardiogram. And so the investigations are grossly for anesthetic fitness, as we have correctly mentioned, the blood investigations, as well as the throat swab part. I think Professor Shah will throw some more light on it. Now we do not routinely do throat swabs because of availability of antibiotics. But previously, yes, in the textbooks, it was mentioned that throat swab should be done because of the possibility of diphtheria as well as beta hemolytic streptococcal infections, throat infections. Other investigations what you have mentioned is okay. So just a question: if the child had come to you at 15 months age with unrepaired cleft lip as well as cleft palate, what is your priority in that case?
Sir, cleft lip would have been my priority then, because by this time, bisyllable words, as you had mentioned earlier, the child has already started speaking those, and bilabial consonants have already started being pronounced. So they will have a more impact on the life. So cleft lip will be my first priority.
So if you repair the cleft lip at 15 months age, definitely you will correct the deformity, like the lip closure, you will achieve a lip closure. But in this peculiar scenario, what we find in our patients in our country, in this part of the country, there are several unrepaired lips and palate which comes. But I think in this case, the cleft palate should be your priority, because the speech development starts at 12 months, and any cleft palate, there should be cleft palate closure at 18 months to 2 years of age, because the speech development is a irreversible process. So so in this case, the palate surgery takes a priority. In ideal situation, your answer should be that if my setup permits, I will do the lip and the palate repair together. But if you are asked to choose one repair over the other, at this age, at 15 months age to 18 months age, the cleft palate takes priority. And moreover, if you do a cleft lip repair, your exposure for the palate surgery becomes theoretically a little difficult, because if it is an open lip and there is a lot less retraction, the cheek retraction, while you dissect the palate, you raise the palatal flaps. So this may be your supporting points if you are given this scenario. So what repair are you planning to do in this patient, or do you need to examine more to select your process or your method of repair?
Sir,
What are you trying to achieve in a cleft palate? What is the aim of the surgery? What are you trying to correct?
Sir, my major goals would be a functional as well as anatomical closure of the palate without any tension, and functional and correction of functional speech development, and also to separate the nasal as well as the oral cavities.
And a
Right.
competent closure of velopharyngeal septum, closure of the velopharyngeal
Yes.
space as you go for speech.
Yes.
Right. So you want to achieve a velopharyngeal competence for normal speech development, as well as to prevent nasal regurgitation. You want to separate the nasal cavity from the oral cavity, the air passages from the oral cavity by a palatal closure. What is a wide palatal cleft? Can you give us an idea about what you consider a wide palatal cleft?
So more than 2 centimeter gap is wide palatal cleft.
Yes, there are various controversies regarding describing a wide palatal cleft, but to me, what I know is that there are two palatal shelves on two sides, and there is a gap in between. So if the gap exceeds the width of one side of the palatal shelf, then it is called a wide palatal shelf, because 2 centimeter is only a measurement and it can differ in individuals. So because each flap moves medially to certain extent, and if the width is more than one palatal shelf, it is difficult to achieve a closure by the conventional techniques. You have to do certain maneuvers. So what are the methods of cleft palate repair? Mention a few methods.
Sir, I know about the Langenbach operation, the VWK operation, and associated intravelar veloplasty in these two cases.
Sorry, Dr. Shreya, my video got stuck. So can you tell me again what
techniques
sure,
of repair?
Yes, sir. Sir, I know about one Langenbach surgery. I know about VWK surgery, and we have to associate both these surgeries with intravelar veloplasty.
Right. So what is the full name of the VWK? Can you tell the name of the surgeons? It is otherwise known as
Yes.
Oxford technique because it originated in England in Oxford University Hospital. So it is View, Wardle, and Kilner.
Kilner, yes, sir.
Yes, VWK. And von Langenbeck is the initial. It is a method, the earlier method of palate repair. There are other methods as well. The methods what we do now is the two flap palatoplasty by Bardach, BARDACH. That is the standard technique now, with of course intravelar veloplasty. So in a patient with cleft palate, if you are planning VWK, what is the specialty of VWK? Why did it become popular in that time? What is the advantage?
Sir, it gives extra length. VY plasty
That's right.
is done.
It is otherwise known as pushback palatoplasty. What do you mean by pushback palatoplasty?
Sir, if the anteroposterior length is short, by doing this method, we can achieve a length more than that.
Yes, right. As Professor Shah was mentioning, the most important point or the most important goal of palate surgery is to achieve a velopharyngeal closure. So if you can gain some length in your repaired palate so that it goes back behind and touches the velum, that is the posterior pharyngeal wall, then it is most important. You have achieved the most important goal of the palate surgery. So in this case, VWK gives an additional advantage that it tends to push the palate back, and additionally, it does not dissect the central part of the hard palate. That is, it leaves behind certain part of the hard palate, the V limb of the hard palate. So in that case, there will be less maxillary dissection, and the more we dissect the palate, the more it gives rise to maxillary retrusion or growth problems. So we have we are walking on a double-edged sword. That is, more dissection gives rise to maxillary retrusion, and in future gives rise to more problems with the physical appearance of the face. So we have to do an optimum part. So in VWK, we leave behind the central part of the V limb. We do not raise it, and it is a unipedical flap. That is, it is supplied by what is the blood supply of the palate? Can you mention the most important blood supply, the palatal blood supply?
The greater palatine vessels, sir.
Yes, the greater palatine vessels that supplies most of the hard palate. And what about the soft palate? Does the soft palate, what is the blood supply of the soft palate? As you mentioned, it is. Yes, the
lesser palatine
the vessels
supplying the soft palate more than the greater palatine.
Yes, so when you raise the flaps on two sides, based on the greater palatine artery, you can even divide the greater palatine as well as the lesser, as well as the hard palate as well as the soft palate, because both has independent blood supply. And the soft palate is supplied by the lesser palatine as well as pharyngeal arteries coming from the superior constrictors, the muscles. What are the muscles in the soft palate? What muscle is the most important for speech, the normal speech?
Sir, musculus uvuli, the intrinsic muscle of the soft palate.
Other muscles?
What are the other muscles?
Sir, we have levator veli palatini, tensor veli palatini, and palatoglossus and palatopharyngeus.
Right. So musculus uvuli. So there are extrinsic and intrinsic muscles of the palate. Intrinsic, as you have mentioned, musculus uvuli. It is only limited to the palate. All the other muscles come from the base of the skull and insert in the palate, like the pterygoid plates. So the LVP, the levator veli palatini, is the most important muscle. It occupies the middle part of the soft palate. the middle 1/3 of the soft palate, and give rise to the levator sling, thereby pulling up the palate. In a repaired or a unclefted palate, it forms a sling and pulls up the palate, and so that the palate touches while we talk, while we speak. The other muscles, like the what you have mentioned, the tensor veli palatini, it has more important function in eustachian tube, as well as eustachian tube function, as well as the palatoglossus, palatopharyngeal superior constrictor, all give rise to a combined effort whereby the palate moves as a whole. So what is the nerve supply of TVP? The tensor veli palatini. All muscles of palate are supplied by which nerve? Anatomy.
Sir, the vagus nerve. There.
9 and 10. Yes, 9 and 10.
9 and
Except the LVP, the levator veli palatini, which is supplied by a branch from the 5th cranial nerve.
Okay, sir.
So now, what type of anesthesia you are planning for your palate surgery?
So we would be giving general anesthesia.
Right.
With, yeah.
So what is the special thing or what is the peculiar thing you do in a palate surgery while you administer general anesthesia? Because general anesthesia is administered and you are dependent on the endotracheal tube. So
yes,
can you mention what type of endotracheal tube?
Oral or nasal?
Sir,
Oral or
nasal
nasal?
nasal will be more preferred, and we have the right angled tubes that are more preferred in these cases.
Yes, so it is the preferred is that you can go for a nasal intubation, and it should be a ringed tube. It should be a non-collapsible tube, the endotracheal tube or the RAE tube. So there will be a cuff to prevent aspiration of fluids into the airways, as well as it should be a non-collapsible tube because of the bend, which you were trying to mention. So we also use throat pack after we intubate the patient. The surgeon or the anesthesiologist, they will give a throat pack. The child is covered well. What is the position of the child while you operate?
Sir, I don't know.
So the neck should be hyperextended. Ideally, the eyes should look at the back wall, and the surgeon should stand at the head end of the table. That is on the head end of the table, and the neck is hyperextended, quite similar to the tonsillar position. Previously, when tonsil surgery was frequent, we used to call this tonsillar position, or otherwise called a barking dog position, like that. Okay, so the child's eyes should look at the back wall, that is the where the surgeon is standing. And what typical instrument is used for exposure?
What is the retractor used for opening the mouth?
Sir,
so initial part, 1 or 2 operative part you have to know, because in palate, in the palate examination, when you are presenting a case of palate, it is more focused on the repaired part, whereas in the lip, in cleft lip, it is more focused on the description part. So in palate surgery, you have to know few parts of the initial basic parts of the palate surgery, the pre-operative preparation as well as. So in this case, as I was telling, what was my question? I forgot.
What retractor?
Retractor. Yes.
Yes.
Yes, the retractor, it is a self-retaining retractor number 1. And we use, in our institution, we use a Dingman's mouth gag. It is a rectangular shaped retractor with provisions for self-retaining part, as well as there are cheek retractors on the side, and there are certain parts where you can lodge your sutures for future use while you are taking bites.
Lloyd
So
Davis is also another mouth gag.
yes, yes, sir. Yes, sir.
Lloyd Davis.
Lloyd Davis mouth gag is another which you should mention. Sir, then I think, sir, Shreya has answered most of the questions.
Well covered. Just a few questions on, suppose this patient came with only cleft lip. So little discussion on just a patient, because they will have a patient in the exam which has only a isolated cleft lip.
Yes, sir.
Just few discussions how to approach a patient of a isolated cleft lip, no cleft palate on examination.
Yes. So cleft. If this patient had a left-sided cleft lip, in our clinical examination, while we present the case, our diagnosis should mention the age of the child, the body weight of the child, the sex of the child, as well as the side of the cleft. So in this case, it is a left-sided, and the complete or incomplete cleft, that is the completeness of the cleft. In this case, it is a left-sided complete cleft in a 15-month-old child, about 12 kg in body weight, female child.
What is the advice at birth, Shreya? What is the advice? Because these are all diagnosed on table, on birth. What is the advice on birth to the mother? Is a complete cleft of the lip.
Yes, sir. So feeding instructions need to be given to the mother that the baby needs to be fed at a 45-degree recumbent position, supported by the mother from the back and the head, and the baby needs to be fed with a palate or a spoon, through which the liquid needs to be given directly at the back of the oral cavity.
In only lip can the baby suck?
Oh, sorry, sir. This is in case of palate also. In case of only lip, long nippled bottles should be used so that the baby can suck well. Sorry.
So in case of cleft of the palate, what you were mentioning, what are the feeding instructions if the patient had cleft of palate?
Sir, in case of a cleft of palate, the baby needs to be held up in a sitting up posture, supported from the back, and fed directly using a palate or a spoon. And the liquid needs to be given at the back of the oral cavity. And frequent burping will also be required because the child will be engulfing a lot of air with the diet.
Hair failure. Yes, yes. And it should be small feeds and prolonged feeds, not trying to feed too much in too short time. And in case of lip, what is the problem? The problem is that in cases of a complete cleft of the lip, like in this case, there is also problem of because the orbicularis oris muscle is discontinuous, so the child cannot latch onto the mother's breast, and hence there is problem of achieving an initial, when the baby is small, initially there is problem of achieving a suction force, as sir is mentioning. So there is also problem of feeding in case of complete cleft of the lip. So you have to give advice to the mother that try to feed in a semi-recumbent position like you are telling, and also frequently burping the child while she is feeding, and then taking the child out, trying to burp the child. And if the child is not able to suck, then express breast milk or formula feeds with long teated nipples has to be given to the child. like the Haberman feeder. There are certain feeders available, like the Haberman feeders. So in cleft of the lip, what is the can you tell me about the development of the lip? Some small points regarding how a lip develops normally.
Yes, sir. The lip, as I have mentioned earlier, sir, develops from the primitive stomodium, which is bounded cranially by the frontonasal process, which is a mesenchymal prolongation from the forebrain, and the first branchial arch that gives rise to paired maxillary and mandibular processes on either sides, which
So
surround
cleft
the
lip
stomodium
arises
superiorly.
due to failure of fusion of which process?
Sir, cleft lip arises due to failure of fusion of the lateral nasal process and the medial nasal process.
No,
Lateral
maxillary
and
process
medial
comes.
nasal.
Maxillary process come from the lateral side.
Yes.
The frontonasal process has got a lateral nasal process and the
Medial nasal process.
medial nasal process. So the lateral part of the lip is formed by the maxillary process, which is fusing with the frontonasal process. The central part of the
Yes,
lip
right.
develops from which part? Central part of the lip containing the
Sir,
philtrum.
it comes from the medial nasal process
That
and
is
the
the globular process.
Globular process. What is otherwise called as a prolabium in a complete bilateral cleft lip. That is the central part of the lip.
Yes. And the lower lip is from the mandibular process on either side.
Yes, sir.
Yeah.
So the typical description of hair lip. Have you heard the term hair lip?
Yes, sir.
So what do you mean by hair lip? How does the hair look, or how does the lip of... Yes, which is very rare. Yeah, which is very rare. That is actually a loss of fusion of the two medial nasal process. Otherwise, the cleft lip which we are talking about today, that is the failure of fusion of medial nasal process with the maxillary process.
Yes. So what is the ideal time for repair of cleft lip? When do you advise for repair of the cleft lip?
I think Dr. Shreya has got disconnected.
Shreya, can you hear us? Yeah, screen is frozen. Okay. Jyoti, when do you repair the cleft lip? 3 to 6 months age. So why do you need to wait for this period of time? So build up the nutrition. Shreya, maybe she's trying to join. Okay. Yeah, Shreya? Shreya, can you hear us? Shreya, audio on karo. Yeah, Shreya?
Yes, sir.
Yeah.
Sir, am I audible now?
Yes, you are audible. So we are discussing at what is the optimal time for repair of soft palate. What do you advise to the mother?
Sir, soft palate.
No, lip. We are discussing lip.
Cleft lip repair time.
Isolated cleft lip.
Okay, sir. Sorry.
Ideally,
sir,
when should?
Sir,
Just
from
carry on.
4 to 6 months.
Okay. What is the defect in the lip? What happens anatomically? If you have a cleft in the lip, what is the anatomical defect there? You find a split. What happens to the lip muscles? Or if I ask you an anatomical question, what is the disposition of lip muscles?
Sir, there are three subdivisions of the muscles of the face, which is known as the muscular rings of Delaire. They can be subdivided into the nasolabial muscles, the
Yes.
bilabial muscles, and the labiomental muscles.
Okay. So orbicular oris is what? Is a complete
So it is a
circular muscle.
bilabial muscle.
It's a
Bilabial.
bilateral, complete circular muscle.
Yes, sir.
Once you have a cleft of the lip, what happens to this muscular ring?
Sir, it is incomplete, and
So
there
muscular
is.
ring is disrupted.
Yes, sir. Yes, sir.
Okay. So Dr. Ask little about repair part of lip.
Yes, sir. So what are the goals of cleft lip surgery? What do you want to repair? Like in palate you have mentioned. What are the goals in cleft lip surgery?
Sir, cosmetic appearance is very important in case of cleft lip surgery, uh, of both the lip as well as the nose and of the entire face, and a normal dentition along with normal speech.
You see, Dr. Shreya, you have to what you have mentioned, what you have tried to mention, you have to be a little bit more specific. In case of cleft lip, while presenting a case of cleft lip, while commenting on the surgery, you have to tell that I want to achieve the primary goal is achieving a comparable lip height. Okay, the problem of cleft lip, a unilateral cleft lip, is when you compare it with the non-cleft side, the cleft side lip is shorter in the height. Okay, so what is the lip height? The lip height is the measurement when you measure the proposed filtral, there is a Cupid's bow in the center. The Cupid's bow has one trough and two crests. Okay, so there is a non-cleft side. So you measure the distance between the columella, that is the base of the nose, the central part of the nose, to the non-cleft side crest of the Cupid's bow. Okay, and you also measure the same point, that is the columella, to the cleft side Cupid's bow, crest of the Cupid's bow. So there is a big gap in this, in between these two measurements. Can you understand? Can you visualize what I am telling?
Yes, sir.
So the primary goal of lip surgery is to achieve an adequate lip height. Apart from that, number two is the completeness of the orbicularis oris muscle. Your orbicularis oris should be together. You should repair it, because in case of cleft lip, the orbicularis oris is discontinuous, even if it is an incomplete cleft lip, even if it is a microformed cleft lip, developmentally it is incomplete. So the cleft muscles are attached to the two sides of the cleft, as well as into the base of the nares, that is the external, the alar, the base of the nose, the alar part. So you have to dissect it and take it down along with the lip, and you have to adjust the lip height. Apart from that, you have to make the Cupid's bow horizontal, which gives rise to much better appearance, like the cosmetic part which you are telling, and the orbicularis oris repair will give rise to a competent lip, thereby decreasing the speech problem. There is another part to the cleft lip repair when it is complete. That is, the another goal is to form the yes sir, the nasal floor, that is the nasal sill. You repair the, or you achieve a nasal sill closure, thereby also improving the feeding problems which may happen in a complete cleft lip. And finally, if there is a collapse of the alveolar segment, if it is a complete cleft lip, it will be cleft of the lip as well as the cleft of the alveolus. So the cleft of the alveolus, if you can correct it, in your initial surgery. If the gap is small, then you can correct it in your initial surgery of cleft lip by doing a gingivo-periosteoplasty, which gives rise to higher chances of eruption of normal tooth, correcting the
Okay, sir.
dentition.
Okay.
So what are the methods of repair? Can you mention a few methods of cleft lip, popular methods of cleft lip repair?
Sir, Millard's rotation advancement flap.
So why is it called rotation as well as advancement? Why it is named like this? Which part
Sir,
is rotated and which part is advanced? This is actually a MCH question.
Because they should also understand.
Yes, sir.
Yes.
So which part is rotated? Suppose it is a left-sided cleft lip. So your rotation flaps should come from which side? The right side or the left side?
Sir, from the right side.
From the right side, from the cleft side. And your advancement flap should come from the non-cleft side. Okay. So it is also conventionally called medial and lateral, medial as well as lateral segments. So you remember this, that advancement, LA, Los Angeles, that is lateral is advancement and medial is rotation, MR, medial is rotation.
Okay,
So
sir.
in Millard's repair, there is a curvilinear incision and the medial part is rotated down, thereby forming a gap in which the advancement flap fits in from the lateral side. This is in nutshell the description of the Millard's repair.
Okay, sir.
So any other techniques, the other techniques which was used before Millard, otherwise known as straight line techniques?
Yes, sir. I don't know the name of the technique, sir. I have read that it was used in very small clefts.
No, it can be used in wider clefts also. It is the Tennyson's repair.
Okay,
Tennyson's repair, Randall-Tennyson repair. It is a straight line repair. Or there are other like Rose Thompson, but all these names you don't know, or don't need to remember. But Tennyson's, Millard, these two names you should be able to tell while you are presenting a patient of cleft lip clinically.
Okay. Okay, Dr. Dash, we have a nice discussion. So up to this part is good enough. In cleft lip, cleft palate, the genesis of the defect, how do you present the case, and then how do you explain the anomaly, and what are the pre-op measures, and what the standard technique of repair. So we have a nice discussion. Thank you, Dr. Dash.
Thank you,
Thank
sir.
you very
Thank you, everybody.
We'll invite you for a few more cases like a postband contracture or nerve injury, just for
Okay,
postgrad students.
Okay,
Thank
sir.
you very much.
Thank you.
Thank you.
Thank you, sir.
Thank you. Thank you, Shreya. You presented well.
Thank you, sir.